Welcome, my friends, to the Bob and Brad podcast, produced by Bob and Brad, the two most famous physical therapists on the internet, in our opinion. My name is Bob. I'm exactly one half of the Bob and Brad team, and I'm joined by Mike Keenitz, who is part of the Bob and Brad crew and has a channel in their own right, which covers Bob and Brad products and other products for review. So it is our extreme pleasure today to be, this is really going to be part of our expert series. We're interviewing people that are experts in their field. And today it is a great pleasure to have Dr. Deb, or Deborah Riczo. Did I say that correct? Riczo?
It's Rizzo, like Ritz cracker.
Oh, Ritz. Oh, Rizzo. Okay. Dr. Deb.
Dr. Deb.
Yeah, Dr. Deb, if you'd maybe give just a little bit of your background so people can know who you are in case they aren't familiar with you.
Sure. I am a physical therapist, and I've been a practicing physical therapist for, I hate to say this, but
I know,
4 decades. So I worked for over 30 years at Metro Health Hospital, which is a county hospital, and got an incredible amount of breadth of experience working there, and focused in the last decade on orthopedics, and developed a method that is kind of the thrust of what my work is now, helping women with pelvic girdle and sacroiliac issues. So that's kind of plus in the 90s and the 80s, when people really weren't doing it, I had a business with teaching prenatal and postpartum exercise classes in the community. And I partnered with a couple other therapists. And so that was really fun. And I got to do a lot of program development and actually teaching the exercise classes. So I have a long history of being involved with women's health, specifically the prenatal and postpartum population, but women's health in general. So.
Awesome. And I'm going to just mention, you have 2 books. Do you have more than that? Or I'm familiar?
No, I don't. I started writing when I retired. That's why I retired when I did, so that I could actually, continue my journey.
I've read both of them, believe it or not, and they are excellent books. They're really written for the layperson, although the professional would get something out of it too, believe me. And the first one is called Sacroiliac Pain. That was your first book. And Understanding the Pelvic Girdle Musculoskeletal Method. And the second one is Back and Pelvic Girdle Pain in Pregnancy and Postpartum. Find relief using the Pelvic Girdle Musculoskeletal Method. Now, these are both on Amazon, correct? And OPTP and
yes.
Correct. So awesome. I'll put those back there. Well, we thought today we'd start off with we're going to talk about the sacroiliac pain issues. So I've got some questions that I've come up with. We got some questions that were pulled off from the internet, as far as, was it Facebook?
Yep, Facebook and YouTube, we pulled some questions from.
Sure. So do you want to describe what sacroiliac pain is? I do have a skeleton here. I don't know if you want to. I do have so
sacroiliac. So yeah, you can point to where the sacroiliac joint is.
And here's the sacroiliac joint.
The joint, right? So like if you put your hands on your waist and your thumbs are in the back, your thumbs were going to go kind of right in the area where the sacroiliac joint is. When you have sacroiliac pain, you can think of it as either being localized, like right to that area, but you can also have pain that travels. So you can have pain that travels into the buttock, into the thigh, sometimes even down the leg. And that's why it's confusing, because it can get misdiagnosed as pain coming from the spine when it's not. So that's
generally you would agree that the pain will not travel below the knee. Is that, or
that used to be the thinking, but there has been research that has shown that it can go past the knee.
Oh, no kidding. So now it makes it even tougher yet.
It makes it even more confusing.
Right.
Yes.
Right. So what do you normally use as your assessment tools or assessment I guess what do you use to assess SI pain?
Well, it's a combination of a lot of things to pull in to make the picture. So I look at the mechanism of injury, like when did it start?
Sure.
You know,
Yep.
because a lot of times sacroiliac pain is either a trauma. So someone has fallen, they were in a car accident and they've had their foot on the brake and they had
That jar. Yeah.
that jar, or they stepped into a hole, fell down the stairs. So some type of trauma. If they're pregnant or postpartum, because we know the incidence is higher with pregnancy and postpartum. And then again, did they have this before they were pregnant?
Sure.
So you kind of have to tease that out. And any other, what therapists call comorbidities.
Sure.
So what else is going on medically with them? What other surgeries have they had? So issues like that. And so we put it all together. I put it all together in a picture. And then of course you have to either clinically look at them or virtually.
Sure.
And put the pieces and parts together. So if I was with somebody, I would palpate them to see where they were tender. But if I'm not, I can have them palpate themselves to see where they're tender. And then of course, have them move and see where they're limited in their movements and putting that all together, as well as looking at their pain and the cycles of the pain. So whether the pain is like constant, not relenting, never goes away. I mean, some of these are what we call as therapists red flags, versus it gets better, it gets worse with activity, kind of putting all these pieces together, as well as any imaging that they may have had done, and then coming up with what therapists call as a diagnosis, a physical therapy diagnosis.
Dr. Deb, do you do compression tests and distraction tests, or I believe it was called Fortin's sign, where you take your finger and point?
I love Fortin's sign.
Okay.
Yes, I love that. So Fortin was one of the researchers actually that his work showed that the pain can go down past the knee.
Oh, really?
And that was actually, I think, in 2009. So, and the Fortin's test, or if you want to call it a test, is like what you said. You take one finger and then you ask the person where their pain is, most of their pain. And I use that all the time, like even for the shoulder, because then somebody will just point to one spot versus doing something like this. So if they point to an area by their sacrum that is within 3 centimeters by 10 centimeters in a rectangle, that's Fortin's area.
Sure. And then plus, if it's replicated, right, they can hit it and then they come back and hit it again. Is that right? I don't know if that's part of the test or not, but so with SI pain, what do you think is normally going on? Is it laxity, tightness, weakness, or possibly all above? Do you feel it's the joint itself, or?
Yes.
Now, I from your book, you were really a big believer, though, that things get out of place, as they say.
We don't have a lot of evidence to be telling people that they're out of a joint or out of alignment.
Sure.
We just don't. So I don't, and I used to do that.
You don't go down
until I really started getting into the research, into the literature, and looking that we are probably doing a disservice, because number one, the SI joint does not really move very much at all. It's minuscule and it's really bound down by a lot of ligaments. But what does, it's not that it's not painful, and it may feel like it's out of joint, but what often is causing it to feel like that is muscles are too tight on one side and too loose on the other, and it's causing a pull that is pulling on the bone and the tendons and causing inflammation in the area. And when something gets inflamed, then we know inflammation causes pain.
Gotcha. Yeah.
So
I believe Dr. James Siriax didn't even believe that SI was a problem because it was such a stable joint. But that's neither here nor there. But Yeah, so this kind of answers my next question. Now, one of your first self-assessment tools you have for people is to actually palpate or feel the bony prominences. And you have to get the book to to have this explained better. But so the ASIS and the PSIS, sorry, I got it. And then also in the pubic region. So I'm assuming that'd be muscles that are tight and have made that area tender. Am I
Correct. Correct.
So now you have it, if it's found on one side and not found on the other, you feel there's an imbalance in the pelvis.
Correct. So those bony landmarks that you just pointed to would be a sign that you are having something going on that's not normal on that side versus the other side. Just like if you had a sprained ankle and you were touching the bones on your ankle and the ligaments that are attaching to it, and then you could have swelling there. So it's really not any different.
Gotcha. So I'm just a little confused because you don't go behind the scenes and explain it from a therapist standpoint, and it's for the layperson. But you have people. Your exercise number one is if they have tenderness on one side, you have them lift up one leg, and you push against that leg, and the other leg is kind of bridging. Again, you'll have to check out the book to see this, but you do it on one side no matter what issue is going on, right? I mean,
Yes.
No matter what side the tenderness is on.
Right.
Can you explain a little bit what's going on?
Well, that's based on that our bodies are not, our bodies look symmetrical, like we have two arms and two legs, and everything's looks symmetrical. But on the inside, we have different weight distributions. And because of that, and really, they don't really know why, but we have certain patterns that happen in our body. Scoliosis occurs usually always with the right thoracic, left.
Oh, interesting.
Lumbar. So the patterns that are found are why the exercise is only done on one side. And I have been using the method since 2008, and then started teaching the method in 2011. I went back to get my doctorate, and I used this method that I was using in the clinic because I started getting people referring to me. Doctors were wanting their patients to be seen by me. Therapists were coming to me. I'm like, well, I think I developed something here just because of my clinical practice. And so I wanted to, I went back to school, I got into the literature, and then I, not published, but I wrote a paper that then I started using for school, that I started using as the basis to develop a course that I started teaching to therapists. So that's kind of how it evolved, because I was seeing so many people, even that were seen by other therapists, and there wasn't a cohesive approach out there. Everybody was doing something a little bit different. And if you have a certain frame of mind that you're out of alignment, you have to get fixed, that's very different than having some exercises at your disposal that you can have and help yourself if you run into problems, and then a strengthening program to prevent you from running into problems.
Gotcha. Yeah. Thank you for explaining that. Mike, we want to show the picture real quick. I don't know if you can catch that. So that's the exercise we were talking about. And, on exercise number 2, it seems like is that more for the pubic ramus area, or is that, what are you trying to accomplish with that? Do you want to show that one?
So the first exercise, not everybody needs to do that has sacroiliac problems. So that's why it's hard I don't want people to think that they should try that first exercise, because if they don't have those signs then they still can have a sacroiliac problem. They just don't need to do that exercise.
And you explained that well.
That exercise is actually working on the component of the muscles that are tight this way, like this way on your body. And so then the second exercise is to address the muscles that are tight this way, our
Gotcha.
side muscles.
Gotcha.
So that's why everyone doesn't have, that's why the method is a step-by-step approach that if you follow step 1, step 2, step 3, then it'll be the right thing for you.
Gotcha. With I'm sorry to keep asking you about all these because I'm just curious from a professional standpoint.
One by one.
This exercise too. That's exercise number 3. Your daughter is very beautiful, by the way.
Oh, yes, she is, isn't she? Thank you.
So that exercise, what are you trying to accomplish with that exercise, or what is that accomplishing?
So that exercise, when you're sitting tall and you have your one leg out, we're sitting perched right on our sit bones.
Sure.
Okay. So when we're sitting, if you're sitting correctly, we're sitting right on our sit bones. So we're trapping the sacrum if we're sitting tall and not slumped. And then when we put our one leg out, we're stretching the rotators on that side, which have an intimate relationship with the workings of the pelvis. So then when we're turning, we're affecting all the small little muscles and the larger muscles and all the ligaments that are in the pelvic area, the sacral area, that may be the culprits.
Gotcha.
So what I have found is that when people do this, they're generally always tighter on one side versus the other.
Is it generally the painful side, or is it does that?
Yeah, well, yes. I always have them start on the non-painful side so that they can feel what normal feels like. And then it's important to do deep breathing with this, and just breathing, because you don't want to be tense with any of these. Because if you're tense when you're doing any of the exercises, then you're going to be preventing the natural movement that should be occurring.
Good. Actually, that leads me to another question I had is about breathing. What do you feel the role of breathing is in pain control and treatments? I mean, do you spend a fair amount of time on that with people, or what are your
It's
thoughts?
the number one thing for the mind-body connection. And if people are having a disconnect there, it's going to be really vitally important. It's going to be more important for some people than other people who might be already in tune to that. But for a lot of people, especially that are in chronic pain, their pain can be dialed down quite a bit if their anxiety and their fear and some of these other things can be dialed down, because we have, 2 systems in our body. We have a fight or flight system that revs us up, and then we have the system that calms us down. Well, the breathing gets us to connect to the system that calms us down, and we all need that during the day. I think. I mean, I need that during the day. I have my little I watch, and it tells me to stop and breathe. And sometimes I find myself saying, I don't have time to do this. And I'm like, oh my gosh, what am I saying? Because I'm a little bit of a type A personality. I don't know if you can tell. So I need to do deep breathing because I need to connect. And if you're in chronic pain, it's very important because we tend to tense up when we're in chronic pain, or even not chronic, even just acute pain.
Yeah, or just normal life. I mean,
right.
So it's been interesting. We'll have to maybe have a conversation on this sometime. So I've been heavy into this breathing thing right now. And
yes, he has.
Yes, he has. And so the big thing that I'm a mouth breather, which is kind of a negative connotation, of course, but it has made such a difference that I've been working on breathing through my nose. And I've seen now studies that have shown that it decreases blood pressure, which it has on mine. It decreases stress. I sleep better. It's been amazing to me. I mean, it's been life transforming for me. So I don't know if you read anything on that or not, but
absolutely. In fact, this is recent for me too. I have been starting to do my treadmill workouts with my mouth closed.
That's what I'm doing.
Oh, really?
I'm trying to run.
It's much harder.
Yeah, it is.
Much harder.
It is. Oh, that's great that you're in the same area.
But so the whole idea is that when you are under stress, that you when you're on the treadmill, and that's like you're starting to increase your workload,
Sure.
that you connect your mind with your breath, so that you are using your diaphragm when you're breathing instead of doing all this upper chest and
Sure.
like that. So that if you keep your mouth closed and focus on the breathing, your body is going to metabolize what it needs as far as oxygen and carbon dioxide in a more efficient way.
Yeah, it's not to be belittled. I'll tell you.
Yeah.
Well, the other thing where we discovered is my wife, when we have 3 children, and the first child, for some reason, we didn't buy into the breathing Lamaze and stuff. And oh my God, the second time was such a reduction in pain and management by just performing the breathing exercises they recommend. So
And actually, unfortunately, there's a lot of people that don't value childbirth classes.
right.
And so they're even missing that education. So yeah, absolutely.
Not a lot. Yeah. So, all right. I see you incorporate some pain neuroscience education in your book. Can you tell us how you approach that with your patients, or you did with your patients or the consumer? Or
Yes, the concept is that, we feel pain, generally acute pain, by, touching a stove, and it comes up to our brain, and that's, we feel the pain. But the perception of pain actually is being registered in the brain. So if you are having pain for a long time, it's been proven, if it's over, I think it's like 3 months, it actually gets processed in a different center in our brain. It's not so much where it came in or where the injury, because there's different places that map out to the brain compared to on your skin. So the processing occurs more in our emotional area. And that's why people can have such pain with just clothing touching, because it's being processed in a different part of the brain. So the analogies work great here. So it would be not paying attention, not actually waiting for the next pain, but doing breathing and not being fearful. So the analogy that I like to use is, if you were walking in your house, being relaxed and comfortable, and then you were walking in your house thinking there was an intruder in there somewhere, and you're looking behind you and you're just like this because you're just so fearful. So people feel like there's an intruder, or there's something bad inside of their bodies, and they're trying to run away from it, and that causes a lot more tension and stress, versus knowing that the pain is there and just trying to de-stress and not make it mean more than what it is.
sure, that's a great example, by the way.
Yeah.
That works out really good. This is a Facebook question. What's the importance of posture in helping with sacroiliac pain?
It's got a huge role. I talk a lot about, because people end up doing things out of habit that they don't even realize can be feeding into the problem. For example, even, the way they carry things. A lot of times women will carry like their children always on that right hip,
Yeah.
or always on that left hip. So if you keep doing things over time the same way, you're going to get tightening of certain muscles on the side you're carrying, if you're shifting that hip over, or even if you're just standing on one leg all the time. Like people will be standing and they'll stand shifted all the way over to that right side all the time.
Yep.
And so that plays a significant role in what is spilling out that we're seeing.
And for me, it's I tend to sit on one side. I don't know why, but I have to constantly, remind myself.
Sitting is huge because we sit a lot now, don't we?
Yes, we do way too much. So, yeah. All right. There was one last question on the SI. How do you decide if an SI belt is appropriate? And is there a certain type you would recommend? That was a Facebook question too.
That was a mic question.
Oh, that was a mic question. Oh.
Sacroiliac belts can be extremely helpful with this population with having sacroiliac pain. if you feel good when you have you can take a regular belt and put it on below your hip line.
Sure.
And give that compression. And if that feels good when you're walking, then you probably would benefit from it. That's probably the easiest way I can tell you, like a thicker belt, like a man's belt.
Gotcha.
Down low, or like those hip hugger belts that we used to wear. You can even get a little bit of a sense if you take your hands, put them on your hips and push, put them this way and push into the joints while you're walking. So you're kind of pushing right in while you're walking.
You're pushing this way.
No, more like, hold on, let me get my pelvis.
Oh, here we go. Oh, here we go. You just got a better pelvis
Yeah,
than
yours
we do.
better than ours.
Okay, so if you push in this way, your hands like this. Not here, because this might actually flare it out.
That might actually distracted.
But you need to push it in this way.
Well, now I'm embarrassed because I've been doing it wrong. No, I have. Brian Mulligan would recommend that you walk behind the patient and, push along to see if it helps. But I was always.
But if I'm behind a patient, I'll put my hands like this and push in with my thumbs. Because you want the pressure going toward the joint.
Makes complete sense. I was doing it wrong. Sorry. So, is there anything else you want to add about SI pain that I know we didn't cover everything, but I thought that was a good introduction for everybody.
I teach a full day course.
Yeah,
on
right.
Sacroiliac and pelvic girdle pain. So no, we didn't cover everything.
No, not even close. Right.
Yeah.
Thank you for your expertise on that. But
you're welcome.